Fundamentally, the age of the female is the most dramatic cause of infertility.
Emma Whitney is the Director of Embryology and Genetics at the Evewell Fertility Clinics.
We are in a fertility pandemic. We expect women to work like they don't have children, but we expect them to raise children like they don't work. What I will say is that the AMH level does not tell us about your chances of conceiving every month. Why did no one tell me this? If you're not having a period after coming off the pill or whatever contraception you've been on, I would be in front of my GP within 8 weeks.
She takes to Instagram as Emma the Embryologist to ensure people are informed about their reproductive options with a realistic expectation.
We also know that in the last 50 years, male sperm counts have declined by 50%.
What can people do to improve their chances of a successful pregnancy?
What I would like to say about egg freezing is it doesn't give you a guarantee.
Do you have any advice to people going through this journey when it's not going as smoothly as they'd like?
You're not alone. It's a lot of people in this world going through this journey. I think we don't talk about enough. What you can't do is turn back time.
Hello everyone and welcome back to Vision of Health, the podcast where I talk to qualified experts about what being healthy really looks like in everyday life. I'm Dr. Frankie Jackson-Spence. I'm a medical doctor specialising in cancer research. My mission is to bridge the gap between science and real life, offering you practical advice to help you improve your lifestyle that is actually backed by the evidence. I'm Dr. Frankie and this is my Vision of Health. The conversation surrounding fertility and trying to conceive is a really sensitive one, and many of us unfortunately know someone going through a difficult journey with fertility challenges affecting 1 in 7 couples. When it comes to health, knowledge is power, and our next guest is here to open up the conversation surrounding fertility, egg freezing and IVF. Emma Whitney, welcome to Vision of Health.
Thank you very much for having me.
Thank you so much for coming on. I'm really excited about this conversation. I'm at the age where this is definitely a topic of conversation amongst my friends and colleagues. And I think we just need to be opening up the conversations around this so that people can make choices earlier and be well informed. And everything you do on social media in that regard is absolutely brilliant. So I'm really excited for this. Fertility rates are declining. Why do you think that is?
I think it's layered. I think there's multiple reasons. I think we are in a world where women are expected to be everything for everyone. They're expected to have big careers. They're expected to be able to, drive forward that narrative, but they are also then expected to reproduce and be mothers. And the quote I heard once that sits with me and probably is a really good place to start this is, we expect women to work like they don't have children, but we expect them to raise children like they don't work. And it can't coexist. So we are aging. Women are definitely, the average age now for a woman in London to have her first baby, I believe last year was 31. If you go back 50 years, it was probably 22. Fundamentally, the age of the female is the most dramatic cause of infertility in the human race. But also we're living lifestyles where we are being subjected to more plastics and more toxins and all of those things. And that is affecting everyone's fertility health, including the male reproductive system. We also know that in the last 50 years, male sperm counts have declined by 50%. It is massive. We're not really clear on exactly what it is. Like I said, it's probably layered. But we are in what I would scarily call a fertility pandemic.
Wow, it's really frightening when you hear those statistics. You really kind of hit a nerve there when you said about women being expected to do so much. I heard a quote once and it was like, you can have it all, but at what cost? And I think that's very true. I love that quote. So what exactly is the link between infertility and age? So
women are born with all their eggs, which means that it's really hard to explain without a diagram, to be honest. But when women are born, they're born with eggs and they go into like a dormant state. An egg is literally the biggest cell in the human body. And inside it, there are 46 chromosomes. I'm not going to go too much into genetics because it all gets really complicated. But for an egg to be viable to create a new human, it has to halve that chromosome number to 23. So that when it meets a sperm that is 23, it is then able to make a new 46 chromosome entity. It is basic maths. When we are born, our eggs are in this dormant state. And when they become ready to ovulate, they have to be reawoken. And that chromosome splitting mechanism has to happen every month as we ovulate new eggs. Now, as we get into our mid to late 30s, those eggs have been in our body in that dormant state for a really long time. And so they make more errors. And so when we have more errors in the egg, we have more miscarriages, we have more failure to conceive, so negative pregnancy tests, and we have a longer road to any conception. So as we age, it makes, like I said, it's basic mathematical sense that the more errors the egg makes, the less likely we are to conceive. So the link between fertility and aging is simply that. It is simply that the egg has been in our bodies for so long that as they are released, they are just making more errors than they did when they were in their 20s.
So there's an element of the number of eggs reducing, but also the egg quality reducing.
Yeah, so you're born with about, I think women are born with about 2 million eggs. By the time we are in puberty, we have about 500,000 left. And then that will reduce throughout our lifetime. And by the time we hit into our early 40s, we're in a pool of eggs that then starts to trigger the impact of menopause. Once the egg number decline, menopause begins.
I see. And is there an age where, you mentioned about the kind of age-related wear and tear and quality of our eggs reducing, is there an age where that starts to reduce more significantly?
I think I hate the term a cliff because there isn't a cliff. We're not all falling off a cliff at 35. But we know definitely as we get into our mid to late 30s, the decline in the eggs being able to be quality controlled, for use of a better phrase, definitely becomes more profound. The decline between 35 and probably 38, 39 is quite steady. The decline after 40 is quite dramatic. Mm-hmm. We see, especially when I'm in a lab trying to create embryos, I can fundamentally see year on year after 40, quite a steep, like negative curve of being able to create viable embryos. Yeah.
I've had a conversation similar to this on the season 1 of this podcast, and it really caused uproar, particularly on TikTok, with people racing to the comments and saying, well, I had a healthy pregnancy at 45. Why are you trying to scare people? And I really want to emphasize that when we're providing these statistics and these facts, it's not trying to scare people. It's to just provide the facts and people can do with them what they want to do. But I'm sure this, hearing that again is going to have a similar effect. People don't want to hear this, but I think it's all the more reason to have these conversations.
It's about raising awareness. And I think, take my job, for example, as an embryologist that is patient facing. The one thing I get asked every single day is, why did no one tell me this? Why did no one tell me that reproductive aging has such a profound impact on the ability to conceive a healthy baby? So we're just here to tell you. Like you say, what you do with that information is, I get that it can be really emotive, but it is fact. It is biological fact.
No, I completely agree. AMH testing has become very readily available. Do you think it's a useful tool for people? So
AMH stands for anti-Mullerian hormone. It is the hormone that each follicle, or what we call your antral follicle, so the tiny follicles in your ovaries before they become mature and ovulate, they give off this hormone. The AMH value basically relates to your natural ovarian reserve. It does not tell us about your egg health or your egg quality. What it allows us to understand from a reproductive treatment capacity is what level of drugs we would need to give you if we were going to stimulate you into a collection of eggs, which I think we'll come on to later. I do think AMH is a great understanding of your own bodily function. I also think it can be really scary that if you are 30 or 28 or 30 and you have what is considered a low AMH, I think people can understandably get very distressed about that. What I will say is that the AMH level does not tell us about your chances of conceiving every month. What tells me of your chance of conceiving every month is your age. And whether or not you have a lower ovarian reserve or a higher ovarian reserve, the quality of your eggs being able to create a healthy baby is actually driven by the age that they're at. So it's got nothing to do with AMH. And if your cycles are regular and you're ovulating and you're of a good age group that has a high reproductive chance, then that has nothing to do with your potential to get pregnant naturally. The AMH is really important to understand where you're at in your reproductive years. But actually we use it when we're trying to create eggs for egg collection so that we know what drugs to give you.
I'm all in support of people getting, their data and their knowledge to make decisions. But I think that's really important because I think sometimes the translation into what you should actually do with that information is sometimes lacking. I'll give you an example. I have a few people I know who have done these readily available tests and had low AMH and are in marriages or stable relationships where they think, okay, this has triggered me, maybe we should start having conversations earlier. Or also some that have thought, oh, I'm really not ready, maybe I'll pursue egg freezing and things. And that's fine. That gives them some information that helps make decisions. I think that's great. On the flip side, I did one of those tests and had a reassuring AMH level. And I do sometimes wonder if it's given me a false sense of security, because I'm 31 and I have kind of taken a sigh of relief when I saw it was normal. And I wonder if, had that not been available to me, I'd have got to 33, 35 and thought, oh, I should probably be thinking about this now. Whereas I'm probably now sitting on, but I had a normal result.
Yeah, no, you're absolutely right. So I think it's the conversation. I think actually what we need to talk about is responsible reporting of results.
Yeah.
So that when these results, like you just said, are readily available, there are companies that are more responsible at giving these results than others. And it should come with advice. It should come with a caveat. It should come with, what does this all mean? You shouldn't just be given a blood test result and told to interpret it yourself. It's great that your AMH is normal, but even with normal AMHs, I think you're absolutely right. We still are dealing with an age fertility decline, regardless of what our AMH tells us. What my AMH tells me that yours is normal is that you would be able to do an egg collection with a really good number of eggs to create embryos. It doesn't change the fact that those eggs will age.
Yeah, and it doesn't tell you about the quality.
No.
So besides age, what other things may be decreasing our fertility?
So there was an amazing report that came out about so we call it, I like to term it as what is causative problems and things that you can't control.
Yeah.
So we know things like some people have PCOS or endometriosis, or some men are unfortunately affected by mumps when they're in their childhood years that can make them have really low sperm counts. There are genetic diseases. A lot of this is something we don't have control over. It is something that unfortunately we learn as we're potentially unable to conceive. But there are things we can do that change our reproductive health. And Fertility is a company who very, very recently launched a reproductive report. And they looked directly at the effect of factors that we put into our body and then the association of that with the blood tests that we were getting. And one of the most profound things that they found was vaping. Vaping and smoking for male and female reproductive health is chronically detrimental. So I think we need to talk about what we can do to protect our reproductive health. And for me, that comes down to education.
Absolutely. And I think what's also scary about these lifestyle habits is that you mentioned you're born with all your eggs, which means if your mum smoked or vaped, that may affect your egg quality.
Yeah, we're not quite there yet, I don't think. But yes, I mean, fundamentally, what we know about what vaping does to AMH levels, for example, we know it decreases it. We know it actually fundamentally has the ability to reduce your ovarian reserve.
Yeah.
Yes, surely there's got to be an ongoing generational effect, knowing that is how we are created as females. And I don't think it will be any different for males, because there's obviously epigenetic health and all of that we could go into. But yes, there's lots of factors now we know. So we know that obesity is a real problem with male reproductive health, because anything that makes the testicles hot is an issue. So there are things that we just need to be aware of. Our certain diets and lifestyles, we can absolutely have control, a little bit of control over some of the bits we cause reproductively. We can't control the bits we can't control, but we can gain knowledge on that. I've actually started going into schools to try and get to the younger generation of between 15 and 18.
I love that.
Because that is where they are starting to vape. They are starting to have sexual intercourse without protection. And another thing we can control is whether or not we catch a sexually transmitted disease. And a lot of the work I do is from women who potentially did catch chlamydia in their 20s, went undiagnosed, and now have tubal problems with their fallopian tubes. Same as men with their, with their own vas deferens, which is their tubal system. So for me, it's like women sitting in front of me and saying, why did no one tell me this? I almost can't change that journey for them. I can help them where they are now, but what I'd really like to do is get them really young and say, these are the facts, do with them as you will, but at least we've told you.
Yeah. I think that's a when we're talking about whether people should do the tests, I think that's useful. You know, if you are someone that maybe has less healthy lifestyle behaviors like vaping or smoking, or you find some sort of like undiagnosed thyroid condition or something, then that's useful because you can make changes and it sparks you to make change. But I agree, we need to be having these conversations earlier, because I feel like prior to like the last few years, people often face this when they're really trying to conceive, and then it's faced with a moment of panic because you're in that high pressured journey already. Whereas if you have these conversations before you're even really thinking about it, you can actually make changes, which can take a bit of time to take effect.
Yeah, and I actually think there's a lot of guilt that comes with this.
Yeah.
Like when you're faced with this and you're like, again, why did no one ever tell me this? But why? There's a huge amount of guilt and mental health that goes on with being like feeling that you're causing your issues with conception. There is no blame here. These are things that we've not been told, and we absolutely need to be told. But I think that having to face that while struggling to conceive can be massively overwhelming. You definitely see it in people.
I bet. Final question on kind of AMH before we move on to what people can do to improve their chances. What other things can lower AMH? Because isn't there something to do with contraception?
So when you're on contraception, I'm not a clinician, so like yourself, so I can't go into it too much, but the AMH level can be affected by contraception in the fact that if you did an AMH test and you were on the implant or on the pill, it may be perceived as lower. It doesn't mean that it's caused it. It means that when you come off that contraception, it will regulate itself. There is no evidence that contraception causes a reduction in fertility. And I think that is one of the things that we need to myth bust, because actually going into schools, that is what they think. They think that contraception will make them infertile. There is absolutely no evidence for that. But yes, understandably, it does suppress your reproductive system because that's its job. It's trying to stop you becoming pregnant. So if you were to do AMH tests whilst you were on certain hormonal contraception, it definitely needs to be written into that caveat that we talk about, that this may be reducing that level to something that probably isn't representative of you. So some people choose to come off that contraception and have an AMH test done about 3 to 6 months later.
I think hormonal contraception is just absolutely getting a beating on social
really
media
is.
at the moment. I think what people need to remember is that many women go on contraception at a young age, teenage years, either because they've got some sort of heavy periods or painful periods, which is probably some sort of condition going on underneath that may cause you naturally to have reduced fertility, or they go on at an age where they're young and they don't actually figure out what their normal periods are like. So then they come off at 35, find they have irregular periods, but blame the pill.
Absolutely. It's another thing I've been doing in the schools especially with the girls in the schools, is saying to them, myth busting again, it is not normal to be having such heavy periods that you're, what we call flooding, and it's not normal to be crippled in pain, and trying to get that into their understanding so that they can go to their GP and actually understand that this isn't normal. Exactly all of that.
Yeah. I had a patient yesterday actually who had really bad abdominal pain from a cancer she's got, and she was really excusing the pain. She was like, oh, I know it's fine. I've had a hysterectomy. I've been through way worse pain than this. And I was like, but that isn't normal. That's not okay. You shouldn't have had to go through that. Yeah. And we really normalize it. I'm glad you touched on that. So for someone who is on their trying to conceive journey, I've not been on one, but from what I can see, it seems like a roller coaster.
Yeah.
What can people do to improve their chances of a successful pregnancy or conception?
So again, I think, firstly, back to real basics, understanding your menstrual cycles, using apps to track them. I'm not even going, not people that have been on a trying to conceive journey for years, because that is a completely different conversation. But for people just thinking that they want to potentially start trying to conceive, a female understanding her menstrual cycle is key. Understanding when she's ovulating, understanding how that all works. And then actively trying to conceive around those fertile days for a female. Also for men, actually regular ejaculation is really important for sperm health. There is no keeping hold of it for a month and then only utilising it when your wife or partner is ovulating. It's about, we are mammals, so behaving as mammals would, which is for men ejaculating regularly. Also looking at your lifestyle. We know that, again, being overweight, alcohol intake, smoking, vaping, all of those things can actually delay your time to conception. So taking some time to get that in a place where you're looking after yourself will actually help you conceive. So if we talk about male reproductive system, a sperm takes 78 days to be produced, roughly 74 to 78 days. So we always say to men that
That's
actually
longer than I thought.
Yeah. But you can make really positive changes to sperm health in 3 months.
Yeah.
By cutting out the alcohol, the smoking, the vaping. We know a Mediterranean diet is brilliant. Eat the rainbow, all of that. But even for women, a woman's egg from its tiny, tiny weenie follicle to being an ovulated or ready to ovulate egg also takes 3 months. So you can do it together.
Yeah.
And it's about, those are positive things you can do to help conception. But I think actually a lot of it is about education. It's understanding your menstrual cycle. Because the amount of people that I speak to who aren't on a IVF journey, but like I said, like friends and stuff, that don't actually even know when they ovulate. So stuff like that I think is really important to start with. And there's loads of apps that help us with that now.
I think it's difficult if you spent your whole life on contraception, which for many cases prevents ovulation. I've got 2 things, just spin-off questions there. The first is, if you're on hormonal contraception that inhibits ovulation, does that then prolong your fertility because you're not ovulating your eggs?
No, it doesn't, because we haven't seen that actually. No. Actually, if you're on a hormonal contraception, when you come off it, your body should regulate very, very quickly. I personally wouldn't give it more, if you're not having a period after coming off the pill or whatever contraception you've been on, I would be in front of my GP within 8 weeks. Because it should regulate very quickly in women.
Yeah. And similarly, I've also heard people that come off and then on the next cycle get pregnant. So I agree. If anything doesn't feel right, definitely speak to your GP. Talking there about male and female, egg count and sperm count things. Can women therefore improve their egg quality through these lifestyle changes? Because we're born with all our eggs. So how does that work?
So you can definitely improve your chances of conception. There is definitely a lot of evidence for lifestyle changes and making appropriate changes. So if we talk about it in my world with IVF, we definitely see potentially a better response to the stimulation when we are in a much more nutritioned place and we've done what we call the pre-prep work of 3 months. What you can't do is turn back time. So you can't change this aging process. So when I sit in front of women who are of what we call advancing maternal age, the prep is really important, but time is more important. So it's a real balance between, you don't send someone that's 41 away for a year to do loads of prep work, because that is chronically detrimental to egg health. So it's about that balance of what changes can we make that isn't going to impact on that time delay. So I think we need to have context about what age we are coming to this at, so that we are informed about how long do we leave this and where's the way up on this.
I guess that leads me on to a question of, at what point should we start thinking about this? Would you recommend it so when people are imminently thinking about getting pregnant and they think, okay, let's start trying and let's start doing these things? Or do you think that we should all be kind of doing these things anyway?
I think we should be thinking about this from school age. I think we shouldn't, and it doesn't mean you have to do something about it, but I think you should be aware. I think that you should have an awareness and you should be educated on menstrual cycles, reproductive health, trying to conceive, how we conceive, what we can do to change that. What are the red flags? When do I need to get in front of a doctor? Most people don't know any of this. So I think it should just be part of our, like we get taught how to drive a car and we drive a car. I just think it should be part of what we're taught and we know about, so that we can make choices.
I remember always learning, men should eat tomatoes to improve their sperm quality. And I'm like, well, men should eat tomatoes all the time because it's just a good thing to be eating.
I think that's selenium. Yeah. I mean, if we eat, like you always say on your Instagram, if you eat well, why does that have to be a diet?
Yeah.
It should be what we're doing. And if you choose not to do it, you choose not to do it. But have that level of education to, I come from an age where all we were told at school was don't get pregnant and here's how you put a condom on a banana. I mean, thankfully we are further along than that, but it's still not part of fundamentally the academic education system, teaching women about what is normal, what is not normal, and for young boys and pubescent males, what all this looks like and what you can do to affect it.
I think the conversation surrounding what men can do in particular has increased. I've definitely noticed that. It feels like the responsibility was always on the female.
Yeah.
And now the conversation is definitely more leaning towards that. And I think that's because what you started with, the male sperm count numbers are reducing.
Yeah.
Are there any differences between what male and female should do, or is it just general advice like the diet, smoking?
Yeah, there is all of that. But I think with men, I think the reason the conversation has changed so much is we used to think that it was, I can't remember the exact statistics, but we used to think it was 50% women, 30% unexplained, and then like 10% men, I think when I started embryology in 2002. We now know it's 50-50. And the reason is because a man's sperm count can look completely normal, but we now know so much more about the impact of the integrity of that sperm and the health of that sperm to create good quality embryos. There's now fundamentally a lot of research out there that show that men with inherently poor quality sperm, even though it looks visually okay, can lead to more miscarriages. So we now really understand that this is a journey of 50-50, which makes perfect sense. And I'm really baffled that it's taken us this long to get there. So there is so much more now that we know about male sperm health that is helping us educate men. When I started embryology, the men didn't even come to the appointments.
Wow.
It used to just be me talking to a woman, and then she would tell her partner that he had to turn up at some point to provide a sperm sample. And it was so female heavy on them.
It's a lot of weight to
And
carry.
now it's so different. It is very much a couple's conversation if it is a heterosexual couple. So no, we're definitely in a place now where we know that 1 sperm count, 2 sperm counts, they look normal. It doesn't let you off the hook. You've still got to do the work. It's still not okay. We now know that vaping causes DNA damage in sperm. And that fundamentally can cause your partner to be having miscarriages. So the responsibility is on both parties.
Oh, that's good to hear. Just one final thing. I think people really like to be able to quantify what they need to do. There's that thing, isn't there, that once you get pregnant, you've got to stop drinking. Do you think people who are on a trying to conceive journey should completely stop drinking alcohol, or can you have a little bit?
No, I agree. This is so hard, because I think if you read the papers, it would say you shouldn't drink at all.
Yeah.
I equally think that having lived through my own difficult road to parenthood and watching hundreds of people every year go through this, you have to have a life. Otherwise, your mental health and impact here is trying to conceive can be this really exciting, wonderful thing. And if it happens really quickly, it's brilliant. You know, it's like a really exciting time and you can do it together. But actually, when it starts to take 12, 18 months, 2 years, it is hard, and it's mental. The mental health implications of a trying to conceive journey that is challenging is brutal. And I think we have to have some balance. We have to remember to live. So no, there is no evidence that, as far as I'm aware, of the odd glass of wine here and there and having a night out with your friends and a nice dinner is going to change that. I think it's about what we talk about all the time. It's moderation, it's about being responsible. But I always say to patients, there is no point in me getting you pregnant if I'm going to break you on the way there. Because
I mean, my experience from seeing my peers go through it is not the happy, smiley journey. And I'd like to just ask, at what point should people be concerned? Because you mentioned they're 12 to 18 months. I have friends that are panicking after 6 months, and I'm trying to reassure them, that actually can be normal.
So again, it comes to context and age.
Yeah.
And when I talk about 12 to 18 months, it's because unfortunately sometimes an IVF journey can take that long to even be successful. I think people think that you can have a cycle of IVF and it cures everything. And unfortunately that, in many cases, yes, that is the case, but in a lot of cases it isn't. I think if you are in your mid-30s, I think after 6 months, I would be going to my GP, knowing that we are in a bit of a time-dependent window where we need to start looking at, just for basic bloods, menstrual cycle discussions, sperm counts, all of those things can be done in the GP after 6 months. So what we normally say is that women under the age of 37, in the first 12 months, 85% of people will be pregnant. That doesn't mean with a live birth. That means having had a pregnancy to prove that the reproductive system is hopefully working. We then say in the next 6 months, it only actually goes up to 92%. And then in the next 6 months, it goes up to the 94%. And then you've got your 1 in 7 couples that need help, all those statistics. The point is, if you're not conceiving in that first year, that leaves you in the very small 15% that probably need to have some investigations. But I think if you're in your mid to late 30s, you should be in front of your GP within 6 months.
But similarly, if you haven't got pregnant after 2 periods, don't panic.
No, absolutely. Oh my goodness, no. I suppose I'm so used to having the other side of the conversation. No, absolutely not. It's so in a woman under the age of 35, I think the chance of conception is between 12 and 15% every month.
Yeah, it's not as high as you think, because I've had friends, or you've heard stories of people that go on these fertility journeys and then are so stressed. I'm sure that's a contributing factor to why nothing's happening, and then put it off and then suddenly get pregnant. And it's like, is that stress and the...
I don't know. I've never seen the evidence for cortisol being the stress hormone and fertility. I think there can be two sides of that double-edged sword, is that I think people feel the need to tell everyone just to relax, which is not what you want to hear when you're 8 months deep into a trying to conceive journey. I think it's about time. I think sometimes people get really stressed after 6 months, and actually we go into that year-long window and 85% of people will hopefully get there. I'm a big believer in getting the tests early and advocating for yourself, and knowing that when you are going into the next, because I think we need to be really clear on how hard it is to have timed sexual intercourse for month after month after month. It is hard. So I think GPs are a lot more supportive now of doing early blood tests and making sure that things are ticking over.
Yeah.
Sperm counts, actually now you can do home sperm counts. I'm not a huge advocate for them when you're going into IVF, but I think they are brilliant if you feel that you just want a bit of reassurance that there is sperm present. There's lots of home health kits now that we can do that, and they're perfectly fine if they're used, again, responsibly with the right advice.
Let's move on to egg freezing. I'm very interested in hearing about this. What actually happens in egg freezing? So
I think we talk about egg freezing as being very different to IVF. And fundamentally, it's not.
I've split them in my questions.
No, and it's not. So if you can imagine, on a fertility journey, you're on a train. This is one of my colleagues' favourite analogies, and I'm going to steal it. But if you're on a train and you get on the train and the egg freezing is just getting off the train early, all women going on a fertility journey, whether they're with a partner and doing IVF or whether they're coming to it by themselves and doing egg freezing, involves a round of stimulation. So what that means is we give you drugs so that we can make your ovaries give us a reasonable number of eggs. On a normal menstrual cycle, you will ovulate 1. Some people ovulate 2. It's quite uncommon. But what we're actually trying to do is make your ovaries give us more eggs from what is available that month. So you get on your IVF train, and for egg freezing, you just get off at the first stop. We do the egg collection and we put the eggs in the freezer. And actually, for people that are having IVF, you just stay on the train and we create embryos with the sperm that we're given. So it's like a pause of the train. It's like a train journey that then stops and the eggs go in the freezer. So we would create these follicles. You have lots of scans throughout a couple of weeks. It takes about 2 weeks to do. Then we take you to what's called egg collection, which is done under sedation. It's very quick. It takes about 7 minutes. And then we remove all those eggs from the follicles. Those eggs go into a lab and they are put in the freezer.
Wow. Who should consider freezing their eggs?
This is a really, really interesting one. So I think there's definitely a point where people who know they want to have biologically their own children and maybe at a younger age and know that that is something they're really concerned about. I'm definitely seeing women under 35 come in more than most. That's our average age now, I think, is about 31, 32. So egg freezing can be done for social reasons. We call it social egg freezing, and that is done for people that want to preserve their fertility because they're worried about delaying conception. We use a lot of egg freezing with oncology patients because of the chemotherapy drugs. So we do a lot of fertility preservation there. Who should consider egg freezing? I think it's a really fundamental choice, but what I would like to say about egg freezing is it doesn't give you a guarantee. And I think it being sold as such is really misleading. The egg is a cell that has, unfortunately, when we put it in the freezer, I make it sound like I'm putting it in the freezer at home. It's actually in a liquid nitrogen tank. It's far more biological than a freezer that's minus 20. They actually sit under liquid nitrogen at minus 196 degrees.
I am kind of picturing like the eggs amongst the chalk ice.
No, it really isn't. They're in massive vats of liquid nitrogen. We freeze them. They're also really tiny. They're about 0.1 of a millimetre in size each. So we have to handle them under microscopes. But an egg is a cell with unknown potential. So until you fertilise these eggs and you grow them into being embryos, we are actually putting eggs with unknown potential in our liquid nitrogen storage. So I think for anyone that is freezing eggs, the take-home message is you can do it for multiple reasons, whether it's social, whether it's Some people are having surgeries that might need to have, if they're having ovaries removed for the breast cancer gene. We could talk about all of the genetic reasons we do it. But it fundamentally is not a guarantee, because we are putting unknown entity cells in the freezer. And I do worry that it is being sold as a come and do this and then enjoy your lives and delay your conception. It just isn't that simple. It should be taken very seriously, and you should be counselled appropriately. It also is very successful. It does work, but it has to be said that embryos are far better to freeze, and we have more knowledge about what their potential is than we do about eggs.
I think it's similar to what I said about the AMH is there is also the worry that you do the egg freeze and you think, I don't need to worry about that now. I can put that to the back of my mind, whereas age is the main factor anyway.
Yeah.
What do you think about companies offering egg freezing to their female employees?
I think it sends a very interesting message. I think it sends a message that, I think having fertility benefits is something we've been fighting for so long as professionals in this field. Getting companies to understand what a fertility journey looks like is something we actually do as a company. We will go into corporate companies and talk to them about what time off their employees need to undertake an IVF journey. And there are companies now that are starting to give IVF annual leave as extra on top of their annual leave, because again, that comes to educating the companies. But we've been asking for so long for companies to give fertility benefits. And this has been something that's come out of that, has become an egg freezing benefit. And I think it's great if your colleagues and employees want to have egg freezing. But I do worry about sometimes the message it sends that come and work for us, work really hard for us, but don't worry because we're going to freeze your eggs and then you can spend more years in our company. And I think, again, companies need to be very responsible about how they offer it. I am so excited about fertility benefits coming out. I've seen people use them and have babies from it, and it's been amazing. But to only offer egg freezing, I think that sends the wrong message. I think it should be encompassed into a benefit for all aspects of fertility treatment.
Yeah. No, I agree with that. How often is egg freezing successful?
So I think to give context here, we will freeze. So we freeze probably about 20% of our cases are egg freezing cases. And most people do that in their early to mid 30s because they are, for a number of reasons, like we've discussed. What we have the statistics on is the eggs that were frozen 5 years ago, because that's how long it's taking women to come back and potentially use those eggs. Also, I think I need to be very clear that 70% of the eggs we freeze will never be used, because they're there as a kind of insurance policy. And I think people that then do that start thinking about having a baby. And actually a lot of people then meet someone or go on to conceive naturally. And it becomes like a thing that was there, but that's not being used. So the answer is, I don't know. It is, for what I've done it and how much I've done it, it is successful. We get good outcomes from it. But there's a whole untapped element of eggs that we don't have the answers about. And also the statistics we're presenting you now are 5 years out of date.
That's really interesting. I never thought of it like that. Would different factors in the freezing process affect success rates? For example, like the number of eggs retrieved, or how many mature, how many survive freezing? Yeah,
so we talk about it as a funnel. So we talk about eggs being at the top of the IVF funnel. If you can imagine a reverse pyramid, at every stage of eggs going through a fertility pathway, even if that's natural conception, there are elements of failures and drop-off. So we talk about eggs, how many will then fertilise, how many of those fertilised eggs make embryos, how many of those embryos are genetically competent to make healthy babies. And all of those things are dependent on what you start with at the top of that funnel. So if you start with 10 eggs and we go through that funnel, we may be left with 1 or 2 embryos. If we are in a reasonable age group where genetics is on our side, for example, if you start with 20 eggs at the top of that funnel, you're going to be left with more at the bottom. So yeah, it does have an effect. And also when you freeze eggs, you're adding in another element of that funnel, which is freeze-thaw survival rates. We used to freeze eggs back in, 15 years ago, with a method that was definitely not as good as what we've got now. What we use now is something called vitrification, and eggs tolerate that about 90% of the time. So then what we talk about a lot with women is how old they are and how many eggs they need to think about freezing to give them a realistic aspect of having a usable embryo at the end. If you're under 35, that sits in the region of 15 to 20 eggs.
Okay. And
as you get older, it becomes more because there are more eggs with errors.
Yeah.
So by the time you're 40, 42, it looks more like 40 eggs, 50 eggs. It's a lot.
So that might take a few rounds of freezing.
Absolutely. And it just comes back to the AMH level, which tells us about how your ovaries are going to respond. So by having that AMH and sitting in front of a doctor, your doctor should be able to kind of guess how many eggs they're going to be able to retrieve from you with a scan. So you would have a scan and AMH, and then we would know roughly what your ovaries are going to give us. And then you can give someone a really informed decision about how many cycles of treatment they're going to need to freeze what is considered enough eggs.
Do we know if the freezing process has a risk to the eggs? Like, can it induce genetic
No, so it can't induce genetic problems, but what it can do is they are a single cell. So they cannot survive that process.
Okay.
So we can lose eggs in the process. We also know that there can be freezing damage, which then can affect the egg's ability to go on and make a viable embryo, which you can't always visually see. So yes, there is absolutely. And this is where it comes to probably when we talk about IVF, is embryos are incredibly more robust at surviving all these processes.
Okay. I always thought that by egg freezing, you're taking away some of your eggs, and therefore are you reducing your natural fertility? But you seem to be saying it's more about egg quality than it is numbers.
So every month we have what's called an antral follicle count on our ovaries. So if you were to have a scan at the beginning of your cycle, your doctor would see maybe 10 or 15 follicles, let's argument's sake, say on both ovaries. What actually happens in a natural cycle is your body regulates your hormones so that only one of those follicles grows and then gets ovulated for potential natural conception. When you still had those 15 follicles, but your body has naturally regulated them. With IVF, what we actually do is shut down your natural regulation and grow all 15.
Okay.
So it's the same. You're not
wasting any.
No, because those 15 that aren't used that month, we go through a process of what we call atresia. So they've gone anyway.
Okay.
So no, it's exact. So it actually, that's why month by month you can actually get different numbers of eggs from women. It's never drastically different. You're right. You know, if someone that's going to get 5 might get 6 or 4, someone that's going to get 20 might get 22 or 18. But those follicles were already there every month. So we're not depleting your stocks. We're just actually maximizing what was there in the first place.
Wow, I didn't know that. If you're going through the egg freezing, so not necessarily the IVF, although I realise it's all part of the same train journey, how can you improve your chances of success?
Again, everything we've just said is getting yourself prepped, stopping the alcohol, stopping the vaping, doing that 3-month prep, making sure that when you go into that stimulation phase, you are in, and also educating yourself, making sure you've asked the right questions. What does this look like? Can I fundamentally do enough cycles? Do I want to do more than one cycle? How long is this going to take? All of those things can optimize your outcome exactly the same way as an IVF journey.
So it takes about 2 weeks. What does that 2 weeks look like? Is it pleasant?
I suppose that's very, very personal. So it normally takes, like, you'd normally have consultations and a discussion first, probably the month before or the 2 months before, or 6 months before, depending on when you wanted to do it. So you normally, on day 1 is your period. And then on day 2, we would bring you into the clinic to do what's called a baseline scan. And that's to look at how many of those follicles are sat there. You then start injections every day for about 10 to 12 days. There's different protocols, different regimes, different injection methods. But ultimately, the idea is to stimulate the ovaries and to not allow them to ovulate. So we give you suppressive drugs as well as stimulating drugs. So the first week, you probably have maybe 2 scans. The second week, you can have between 3 and 4 scans because we're checking on that development to make sure we know when they're the right size. When they are the right size, we will give you what's called a trigger injection, which is the same as the hormone that would cause you to ovulate. And we do that 36 hours before we sedate you, and then we take the eggs out because at 40 hours, you will ovulate those eggs. So it's us watching your ovaries do what they need to do, and we will tweak things as we go through to make sure the outcome is as optimal as possible. So from the time they're collected from your body to the time they're in the freezer in the lab is 2 hours. It's all done really quickly.
But those hormonal injections can have some side effects.
Yeah, I think if you asked 100 people, you'd get different answers from everyone. Some people say physically it's fine. Some people say emotionally they find it quite hard. Some people say physically it makes them feel awful. I think it's very, very different.
And I think that's important because it's often the people that have negative journeys or have a really tough time that are more vocal about their experience.
A bit like TripAdvisor.
Yeah, or a restaurant review, isn't
Exactly.
it? It's you only talk about it if you had a bad experience. Great to know. Who would be offered pre-genetic testing on the eggs or embryos?
So pre-genetic testing, so you don't do it on eggs, you do it on embryos. So you would have to create embryos to do pre-genetic testing. So we've got two types of pre-genetic testing we do. We've got PGT-A, which is for what we call aneuploidies, which is for that chromosomal copy number we were talking about. So to put it into context, there are conditions that probably people have heard about, such as Down syndrome, Edwards syndrome, and Patau syndrome. The reason they have names is because they are compatible with ongoing pregnancy and life to some level. So they are when there are too much or too little copies of the chromosomal material in our eggs and sperm. When we create embryos, we can, in women of advancing maternal age, where we know there are going to be more embryos with errors, if we have a group of, say, let's play a scenario out where a woman is 39 and she has 6 embryos that we've managed to create in the lab, we can actually test those one by one to make sure they have the right number of chromosomes that is associated with ongoing live births. So out of a group of 6, in a woman that is 39, she would be looking at having 2, maybe 3 if she was lucky. And then the question comes with, why would we utilize all 6 when we know only 2 or 3 have that potential? So that's what we would utilize in what we call PGT-A. We also do something called PGT-M for couples where they know there is an inherited family condition, such as cystic fibrosis, Huntington's. And then we can look for specific genes in embryos and only transfer those that do not have the condition that we are trying to select against. So the process in the lab for me is the same. It's growing embryos to a point where they have enough cells that I can take some. We put the embryos in the freezer and then we test those cells for whatever we're looking for.
So if you had 6 embryos, you're basically making sure you're not implanting one that is more likely to fail.
Yeah. So the most likely outcome for embryos that don't have the right chromosomal number is no pregnancy. Actually, it's normally a failed cycle.
Okay.
But the other outcome for them is either abnormal pregnancy or a miscarriage.
Yeah. Okay.
So, and that becomes fundamentally more difficult. So yes, we do use PGT-A definitely in women of advancing maternal age to try and limit how much treatment they need to go through. Also, let's talk about family building, because if you are 39 and you've only just come to this journey and you want 2 or 3 children, your eggs are only ever going to be as young as they are now. So even if we got you pregnant immediately, by the time you sit back in front of us to have potentially a sibling, you'll be 41. So it's about, again, it's education. It's about helping you make informed choices.
Yeah. No, this is honestly opening my eyes so much to this topic. It's definitely one that I put off talking about. So freezing embryos is better. But there's a caveat to that, because what would you do if you broke up and the relationship ended?
So freezing embryos, there's several reasons it's better in regards to survival reasons. So firstly, you've only put embryos in the freezer that have grown. So you're only putting embryos in the freezer that have any known potential to create a pregnancy. That's the first reason it's better. Secondly, they just survive better, because they are, instead of being a single cell like an egg, they're actually about 150 cells before we put them in the freezer. So they are bigger, they are stronger, they are better at tolerating it. So sometimes women choose to go through this journey on their own and will use a donor sperm, which is a little bit different to if you've got a couple coming to it, because you're absolutely right. The minute you put a sperm into an egg, there are 2 people's consent involved. And it happens. It happens that people do break up. And I've seen both sides. I've seen couples where they've broken up and the partner has given consent for the woman to continue using embryos. I've seen it where the couples have split up and the consent has been removed. And I suppose the real big point to make here is that once consent is removed from either party, we are not allowed to use those embryos legally. No matter what the circumstances, both parties have consent and they can withdraw consent.
Would you suggest people freeze a few eggs?
Some people do, actually. Some people do, especially for women that have got, like, for example, PCOS, if they get 30 eggs in a round of treatment and are in a relatively newer relationship. Yeah, I have seen that. I've seen people do half and half.
A little bit of an insurance policy there. I think as well, I remember one of my friends saying to me, but then what happens if you get pregnant naturally or you choose not to then get on the train again and go through IVF? What happens to the embryos?
That is something that I think we don't talk about enough. So the embryos will stay in the freezer for as long as they are paid to be in storage and as long as they are in legal consent. So in the UK, people tend to consent for up to 10 years initially. And then you can at any point withdraw that consent and ask us to dispose of those embryos. You can ask for those embryos to be donated to another couple. You can ask them to be donated to research. There is a huge amount of research in embryos that go on across the globe, trying to work out all sorts of things about why embryos work, why they don't work, genetic health and all of that. You can donate them to a lab for training new embryologists, because we can't train on things that we don't have to work with. You can't manufacture pretend embryos. But yeah, it's a hard question, right? You've created, and I suppose it's the relationship that you have with those embryos. Now, I'm an embryologist, so as a scientist, I have to have a certain scientific relationship with embryos to be able to do my job. For me, they are incredibly important and they belong to people. But for me, they are a ball of cells that I have to look after and nurture and grow. But there is a huge emotion linked to these embryos, and I completely get it. So we do quite a lot of counselling in circumstances like this. I always actually encourage everyone going through this to try and make sure they've got a really good support network, because some of the unknown emotions come out that you're not expecting. And that a lot of that is how you feel about the embryos you've created.
Yeah, I think it's the individual beliefs about at what point it's a baby, I guess.
Absolutely. And
it's to abortion, isn't it?
It's definitely that. And those are, in the UK, we are able to keep embryos up to 55 years for certain circumstances. But it's how long is a piece of string? How long do you keep them? And it's a really difficult one for people to make a decision about something they've worked so hard to get.
Yeah.
Especially when they've come to the end and they've got their family, or they've come to the end and they're not going to continue with treatment. We've got a lot of counsellors involved in these discussions.
But I think also important to remember that the embryos are not guaranteed successful pregnancy.
No, absolutely not. I mean, so different age groups, different reasons that we have embryos, those that are tested, those that aren't. Overall, we look at, we're much better in the UK than we were 20 years ago. About 40 to 50% of embryos in women under the age of 35 will create a healthy baby. When we are dealing with women in their late 30s, early 40s, that drops to about 25 to 30%. So no, not all embryos are destined to make a live birth.
What do you want people to know about egg freezing that many people don't know?
Probably what we've just said is that it's not a guarantee. It's incredibly expensive. It's difficult. I don't know, really. I suppose it's about being informed. I think that I suppose the big thing I want people to know is that you have to still have reproductive awareness. And if it is a family and children that you want to create, then it should be absolutely used appropriately, but it shouldn't be that all out, I'm going to leave this until I'm in my late 40s because I've got those eggs in the freezer. Yeah,
that's really important. Let's get back on the train. So we've gone through the egg freezing process. Next step is IVF. What's IVF? What's the difference?
So IVF is in vitro fertilization. So that essentially means that the eggs go into the lab and we create embryos. Now, we can either do that by mixing sperm and eggs together, which is if the sperm count is normal and we've got no concerns about male health, fertility health, or we can do what's called ICSI, which is when the sperm count is maybe impaired. So we would literally pick up a single sperm with needles and stick them into each egg. We then put the embryos into our culture system, which is where we are able to support their growth. Embryos until day 6, 7. So if you can imagine, your egg collection is what we call day 0. So your train starts on day 0, and on day 0, if you're having egg freezing, you're off the train and the eggs are in the freezer. If you are creating embryos in most UK laboratories now, we culture embryos to what's called the blastocyst stage. Eggs become embryos through the sperm being injected into them or put with them. And the following day is day 1, and that's when we see fertilization. We then grow embryos to 5, 6 or 7 days to this blastocyst stage entity. And this is the stage that directly precedes implantation if you were conceiving naturally, or if we put the embryos back in the uterus at the right time. Embryos up until that stage are within a shell. A bit like chicken eggs, they have to hatch out. So we try and use embryos before they leave that shell, because they become a little bit more sticky and a little bit more fragile. So we wait for them to become very big and invested and ready to become hopeful pregnancies before we either transfer them, do the genetic testing on them, and freeze them. And that is an IVF journey. So the IVF journey starts on day 0 at the top of that funnel. And by day 5, day 6, you're at the bottom of that funnel. And we would probably convert, for example, 10 eggs into 2 or 3 blastocysts. It really is quite a dramatic pyramid.
So from egg collection to implantation, if you go straight through the journey, is actually only a couple of weeks.
5 days.
5 days?
Yeah. So from egg collection to the point of you coming back in to have an embryo put back in is anything between 2 and 5 days. In most clinics now, we will put back blastocysts and they are on day 5.
That is much quicker than I was expecting. Wow. And who should then consider IVF rather than just the egg freezing or embryo freezing?
So if you're trying to conceive and you've been told that there is an issue with conception and that is the road that you're on, then IVF is fundamentally the most successful way of getting there. And it also gives you the ability to create multiple embryos for future pregnancies as well, which is why we talk a lot about family building when we do IVF. Because some patients, although by the time you are in a really deep trying to conceive journey, the desperation is real. It is hard. It's about having that moment of pause and reflection of how old are we? Are we able to come back to this in 2 years and create more embryos? Should we not be doing multiple egg collections now to create embryos now? What's my AMH? How many eggs am I going to get? All of those things should be being discussed before you go into that first transfer situation. So couples trying to conceive, same-sex couples using donor sperm, sometimes come, instead of doing what we call natural inseminations, we would create embryos again for that family building entity that you can get from one cycle of IVF. We can sometimes create 5 or 6 embryos. And if you're doing inseminations, which is when we just put the sperm back in the right place at the right time, again, you're down to that 1 egg a month or that whatever you're ovulating that month. People with genetic conditions tend to use IVF to help remove those genetic conditions from their families. People that have had multiple miscarriages will use IVF to try and again use genetic testing to try and minimize the risk of miscarriage. And again, even we still do a lot of pre-surgical, pre-chemotherapy treatment in women or men where they are undergoing chemotherapy but are in a relationship. So they also will use IVF to create embryos rather than freezing eggs and sperm.
Interesting. How successful is it?
Again, it comes down to age.
Yeah.
So under 35, I would say that you have probably if you get a blastocyst stage embryo, which is the stage of day 5 or day 6 embryo, you're probably looking between 40 and 50% chance of having a baby.
That's higher than I thought.
It used to be around like 20% when I started embryology, but we couldn't even grow embryos past day 3 20 years ago. It was something that's only come along in the last 10 years, 10, 15 years. Yeah, it is. If fundamentally, if you're in a good clinic with really good culture systems and all of that, then yeah, we can make embryos that have got really high potential. As we age, those percentages decline because of the effect of reproductive aging.
So 2 things about age there. I guess there's the age that you freeze the eggs or embryo, but does the age you then implant
No. So it's all to do with the age the egg was when the embryo was created.
Okay.
So you can create embryos, eggs at 30, and you have the same chance at the age of 45 if your uterus is functional, and we can get that to be functional with meds and drugs. You have got the same chance of having a baby as a 30-year-old.
So it does really take the pressure off in that regard, I guess, at the age of that you're going to need to use them. But I guess many people are trying naturally alongside this.
Yeah, most of the time they are. Again, it depends why you're coming to it. I suppose the other thing, take-home message is being pregnant in your mid to late 40s has other medical implications as well. So it's not as straightforward having a pregnancy in your mid to late 40s as it is, because we know about blood pressure, we know about preeclampsia. There's lots of other things that we need to consider. But no, fundamentally, the success rates of embryos working is to do with the age they were when the egg was taken from the body.
So really, I guess if people are on the fence about doing it, it is better to do it sooner rather than later. Yeah, always. If we've got that option, yes. Do you have any advice to people going through this journey when it's not going as smoothly as they'd like?
Support, counselling, honestly, get yourself a community. In the Instagram community, the community that I live in is, people always say to me, it's something they never wanted to be part of, but they're so glad that the people within it are so good. There are so many of us that are actually just genuinely trying to help. And I think actually the support, I always hear from patients, that connecting with people going through the same thing makes this fundamentally easier than it does. Don't be alone. You're not alone. It's a lot of people in this world going through this journey. So I would say, get yourself educated, get yourself advocating for yourself, know the right questions to ask, and get yourself in a community, because we're all here to try and help you through this process.
That's great advice. I'm going to ask my final question. What is your vision of health? What does health look like to you?
Wow, it sounds really cliched, but happiness. I honestly think that this road, especially the world I live in, can be so hard that people forget to be happy.
Yeah.
You have to have a life. You have to, because whatever this journey throws at you, scientifically, some of it is completely out of your control. But we have to find a balance in how long this can take to go through. So for me, the vision of health is being good to yourself, being good, like eating well, all of those things, making sure you're in a really good health space, but also being kind to yourself and being happy.
Thank you so much.
You're very welcome.
I think this conversation is going to help so many people. I've learned so much, and I really hope that if there's anyone on the, my corner of the internet that's going through this, I hope it helps. Thank you.
Thanks very much.
Thank you so much for listening to Vision of Health. I hope you've taken away some practical and realistic health advice that you can implement to improve your lifestyle and get clear on your vision of health. If you've enjoyed this episode, then please do let me know by liking the episode and leaving me a review. If you want to hear more from me, then make sure you're subscribed to the channel. And if you have any friends that could benefit from improving their lifestyle, then make sure you share the episode with them. I'll see you next time.